for that, I first wanted to emphasize what is the healing on the extraction socket first. If we're looking at the healing extraction socket healing, we can kind of divide it in four big stages. One is the hemostasis and the coagulation. Second, inflammatory stage. Third, proliferative stage, and the remodeling and modeling and remodeling of the bone. That's the basic like four big steps how we have achieved the extraction socket healing. And because of that, we do know from our experience also, when we're looking at the extraction socket, the blood first fills in and then makes the blood vessel angiogenesis. And then it comes down to the inflammatory stage. And after that, the woven bone first forms, of course, after having the connective tissue sealing on top of it. And then the woven bone building, and then mineralization of those woven bone, and eventually we have the short bone there. And that is the brief outline of the extraction socket healing. If we're looking at a little more close on the hemostasis and the coagulation, then basically this whole stage is making of the blood clot and preserving of those blood clots, which contains the platelets and red blood cells, white blood cells by fibrin networks. And the initial blood clot helps the hemostasis, stasis, and works as scaffold or the framework for the cell adhesion, which eventually is going to make the blood vessels and connective tissue of the mesenchymal cells and the leukocytes within 7 days. So basically, we first have the blood clot forming, and then eventually it's going to get hardened and making of the blood vessels there. And from there, we're first going to have the connective tissue layer formed. And I'm pretty sure that most of the doctors here do already see those things when we're thinking about the simple extraction cases. When we're taking out the existing tooth, either with the periodontal problem or the normal cases or the trauma, then the first thing that we're seeing is not the bone, but the connective tissue layer. After we have the connective tissue layer, then we have all those things coming after, for example, as epithelial cell migration from the neighborings. And the other thing, the bone forming from the inside of the socket under that connective tissue. And as you saw from a lot of cases before, I'm pretty sure that this presentation that I am doing right now is what we already saw a lot of evidences before in this morning, and also from the last actual surgical case that the Dr. Kim had. What we ultimately wanted to do here in Army is we wanted to use the physiological reaction of the natural body. And what we're really doing is not really wanted to make or build everything, but we're just using the reaction of the body, the natural process of it. And then ultimately, we can have more prediction on the surgery. That's what we want. And on the second stage of the inflammatory stage, during that time, basically what it means is we have granulation tissue. That's what that is. And it's going to have the migration, differentiation, and proliferation of the inflammatory cells. And many inflammatory cells migrate to the healing socket, and within 4 weeks, the fibrin gets clogged and replace it to the granulation tissue. And I'm pretty sure we saw all those cases in our clinics. And third, proliferative stage. That means we have the woven bone. And also that means we already have the connective tissue layer on top of those woven bone. So the connective tissue layer already draw the limitation of where we are going to have the bone is. And until this part, we don't really see the actual bone, but we know there will be the bone basically, and that's what we're going to use. So the modeling and remodeling stage During that time, the woven bone is going to get mineralized and replace it to the mature bone, and which means it's going to be the functional bone that around your implant, so it can bear the load. That's what we have. From different individuals, some takes like really long time for getting all mineralized. And I believe like we do see those kind of situations quite a lot in the clinic sometimes. Sometimes like those mineralization of the woven bone takes really long time. So we still think the soft tissue or the gum is very, very thick, which is not really happening in the real body. So what we ultimately wanted to do is if we can stimulate the site with the dental implant, then eventually we're going to boost up the mineralization of the bone, and that's what we're doing. So we don't really want to use a lot of artificial materials. We want to reduce it down as much as we can, and we can just simply make better condition for the patients just after placement of the implant. And for the concepts of the AMI implant placement, it's like this. We're using the self-cleansing concept and the connective tissue housing concept, bone-driven implant treatment concept, and the fit implantation concept. To understand the self-cleansing concept, it's basically what it means is within 2 days of the extraction, remaining bacteria and the inflammatory tissues going to get removed from the macrophage action. That's what that is. So we know that after we do the extraction, which means most likely we're going to remove the infection source. And from that action, now the balance with the bacteria and the immune system is broken. Now the immune system will win that battle. That's what that is basically. And from that, we don't really have to worry about cleansing out everything that much. Until now, I believe like with the other techniques that we've been doing, we were trying to do the like all clear debridements, but what we're using in the AMI concept is basically saying that it's not that much needed. So the severe curettage or the debridement on the extraction socket will never going to be needed in AMI concept. For that, we do have like quite a lot of the article background of it. For example, Cobella or Fugazotto or Medicari, Crespi. We researched up like all those scientific background of it, and they all says like even if we place the implant with the endodontically infected area, your successful rate itself is not that much different from the healed ridge. That's basically what it says. The reason why is because we already removed the infection source, and that's what it matters. So if we think about the peri-implantitis situation, actually, it's pretty much the same. What we're doing there for the peri-implantitis will be pretty much the same if it's biological reason. Then removing of that implant will exactly work as the removing of the infection source, such as the root of the natural tooth of it. And that's what we're using. And the second, the biggest concept, but the biggest concept that we're using in this system is called connective tissue housing, or you can call it as soft tissue housing concept. And I believe like today, from this morning and the last surgery and everything, it kind of showed the connective tissue housing to you attendees or fellow doctors. So basically what the connective tissue housing concept is saying is within the connective tissue housing, you are going to have the bone. That's what it says basically. So as long as we keep the volume of those defects and we keep the blood clot, then eventually we are going to have the bone around your implant. Maybe it's not existing for now, but later on it will be. And we are using that concept basically. And a lot of doctors are very unfamiliar with this concept because the bone level implants has not been used this concept. Rather than we were using bone housing concept, it's called. And basically, what it says is your implant has to be surrounded by the bone. But what we're believing in this army concept is we wanted to just make sure all the soft tissue, especially the connective tissue, is around your implant and having the proper sealing of it. Then eventually we're going to have the actual functional bone underneath that connective tissue layer, and that's what we believe. And for example, it's like this. So even if your implant itself is really exposed, and maybe you will feel hesitated by just looking at it, but eventually, after you have the connective tissue sealing on top, on the cup part, then you are going to have the bone at the end, and that's what we believe, and that's how we treat our patients. And the third one, the bone-driven implant concept. In easy way of understanding, until now, probably for the bone level implants, most likely I would say, we're using the concept called prosthetic-driven implant concept. What that means is basically we wanted to place the implant where we have the future prosthetics is. That's what we aim on, and that's why the angulation and everything matters a lot, because your angulation of your implant placement has to be matched with the occlusal surface angulation. Basically, that has to be perpendicular. If it's not, then we're going to have a lot of loading on the wall part of the connection of the implant between the abutment and the fixture, and eventually we're going to have the problem there. For example, as screw loosening or breakage of the implant fixture or any breakage of the prosthesis. But what we can do with the MagicCore implant is a little bit different. We can still use the bone-driven implant concept because it has like one piece-like structure, so we don't need to worry about breakage that much. And it has a lot stronger connection between your prosthesis and your implant itself. So what we ultimately can do with the MagicCore implant is a lot easier. So you can simply think as you can place your implant where you have enough bone is. That's what that is. And for that, the next concept kind of follows together. It's called fit implantation concept. And what we wanted to do there is we wanted to, of course, secure the primary stability, especially on the immediate implant. And for that, we don't have much of the bone. And if we're using the bone level implant there, then usually what we're going to do is very different from the MagicCore implant. The MagicCore implant uses the fit concept, and the conventional implants or the traditional implants with the V-shaped threads are using the fixation concept, it's called. Whether you intend it or not, the bone level implant will try to crush into the bone, and eventually it's going to destroy the interbackbone. And because of that, we have the thing called stability deep. But in MagicCore implant, because it's rectangular, very thin rectangular beam thread, it's going to not push or compress the surrounding bone, but it's going to cut through, it's going to slice through the bone. And of course, you do need to prepare everything, and you do need very accurate surgery. But eventually, if we're doing everything as what we planned to do, then the MagicCore implant basically does not show the dropping of the primary stability that much if you're comparing to the bone level implants. So basically, the osteoclastic activity time can be reduced, and that's what we ultimately wanted to earn. And especially for the immediate implant cases, this will matter quite a lot because you already do have very less remaining bone, and you don't want to damage that. If we damage those remaining bone, then we are going to lose the stability, the primary stability very easily, and that's what we don't want to have. So for the MagicCore implant, we're using just different concept for even for the placement. So for that, of course, the minimum damage will be the key point. So we have to stick with the plan and do the surgery very accurately with the plan, and that's what we want. And I wanted to share one of the case, and this is from not me, but from other fellow doctor, and he just performed the actual surgery this morning, and thank you for Dr. Eun-Tet Lee. And this is the case of him, and I just wanted to ask, so I just wanted to share this case also. So the patient came with a severe periodontitis, and as you already saw in this surgery course, not the surgery course, but the case live surgery, like even with this morning and this afternoon. For the magical implants, the severe periodontitis situation is actually not the contraindication of placement of your implant. We are still going to use those granulation tissue and existing connective tissue located on the bottom of your extraction socket. So we're just going to simply remove it, and then we're going to, of course, put some graft. And if we have the defect on the buccal side, most likely if we have the gingival recession on the buccal side, then we can simply relocate those existing connective tissue on the bottom of your extraction socket, push towards to the buccal side. And it's called causeway technique, and we saw actually one of the case just before me. And if the gum level there is pretty optimal, then we don't need to worry about anything. We don't need very severe debridement, but we can just place the implant and put some grafting material around your implant. And eventually, keeping those volume will matter more, and make sure your blood clot itself is not running out from the socket. And as long as we just preserve that, then we're going to have the bone. And of course, for the angiogenesis part, making of the blood vessels, the mobility matters. So we just wanted to make sure the gum is not floppy, make sure the gum is not mobile that much. So we just need very simple interrupted suture 1 or 2 times. Make sure the gum itself is not moving, and that is more than enough. And after the placement, this is the post-op Panorex. And after a week of placement, you can see how the healing is taking place very rapidly. Before, most of the doctors use the open membrane technique in those cases, and because the gum is just too rough to stretch all the way. And with the open membrane technique, having the pretty much similar result, it will take about I would say 5 to 6 weeks. But if we don't use all those, then actually we can boost up the healing, and that's the concept of the minimally invasive implantology that we're doing. So after 2 weeks, you can see the body itself is actually securing the gate closing. It will automatically going to do the securing, the sealing of the gum, and make sure we have the proper connective tissue housing, and that will matter. After 3 weeks, you're not going to see a lot of the gaps, and after that, we're going to have the epithelial cell migrating on top of it, so we won't have much of dropping of those structures. So we won't see those collapses anymore after, I'll say, a month and a half. So after 6 weeks, you can see how the healing got done, and eventually we can restore the whole thing with very simple procedure, and that's what we want. So I just wanted to explain one little thing that I'm going to add.
선생님 죄송합니다. 주어진 시간이 거의 다 됐는데 좀 정리가 부탁드립니다.
So what we're using is connective tissue housing. So again, the connective tissue housing is basically saying everything underneath the connective tissue layer, we're going to have the bone as long as we just keep it. So we can use this concept and we can do the treatments a lot better for the patients. Thank you.